The first thing you notice when you're looking inside the shoulder is the subacromial space is lined by the acromial bone superiorly with the coracoacromial ligament. Here you can see an ablator utilized to expose the bone by removing the soft tissue, which is the undersurface of the coracoacromial ligament. On the bottom of the screen is the supraspinatus tendon, which you'll soon see is torn full thickness. The tear starts on the bursal side and propagates onto the articular side, is what is causing pain to this patient. The next step that we will visualize is a decompression of this acromial space by performing an acromioplasty. An acromioplasty is performed with an arthroscopic burr between 4 to 5 millimeters in size, with usually a resection of between 8 to 12 millimeters of bone. This particular individual had what is known as a type 2 acromion. A type 2 acromion is usually 8 to 12 millimeters thicker than usual and requires that much of a bony resection. This arthroscopic burr is being utilized through the posterior portal while viewing through the lateral subacromial portal to confirm that a type 1 acromion, which is a flat acromion, is finished. Once that is complete and the surgeon is satisfied with the decompression, the view from the lateral portal is an excellent way of visualizing the actual torn rotator cuff. This is just an ability to see the burr and its flutes, which help remove the bone. This lateral subacromial view shows the supraspinatus tendon, which is being probed by the needle through the anterolateral portal and is demonstrated to be full thickness in nature. Although it is considered a full thickness tear, it's actually not a very large tear. It's approximately 1 centimeter to 1.5 centimeters in the AP direction and approximately 1 centimeter in the medial to lateral direction. This can be repaired by using one medial double-loaded suture anchor that can be placed in the medial footprint after decortication of the tuberosity has been performed. This is a Q-fix suture anchor guide drill, which is being utilized to create a pilot hole, which will then be utilized to place the all-suture anchor into the bone. Once the anchor is deployed, the suture can be placed through the supraspinatus tendon for later tying across the top of the tendon. An arthroscopic suture passer will be utilized to pass the suture through the supraspinatus tendon, evenly spread at the surgeon's discretion. Usually the sutures are placed in a horizontal mattress fashion, with 4 limbs of suture coming through the medial aspect of the tear, and then tied across the top into some type of a footprint type anchor. In this scenario, 1 suture anchor was placed medially and 1 lateral footprint anchor was placed. Once the sutures are placed through the tendon evenly spread, they will then be tied across the top of the tendon to reapproximate it to its anatomic footprint medially. Here you can see the 4 horizontal sutures, 2 blue sutures for 1 horizontal mattress and 2 black tiger sutures for the other horizontal mattress. They can be tied across the top of the tendon prior to being deployed into the footprint anchor laterally. In this scenario, once they were tied, they were subsequently then placed into the multi-fix suture anchor from Smith & Nephew. A suture passer is utilized through the lateral subacromial portal to reapproximate the arthroscopic knots across the top of the tendon. Once the sutures are tied, they can then be deployed into the multi-fix anchor and then subsequently secured in the tuberosity. In this scenario, the patient had excellent bone fixation with a very good apposition of the supraspinatus to its anatomic attachment, which will alleviate symptoms quickly and result in rapid rehabilitation. The finished product is then visualized through the lateral subacromial portal to demonstrate a nice reapproximation of the tendon. In addition to the minimally invasive aspect of the surgery, the recovery is accompanied by 4 weeks in a sling with gentle motion, and then approximately 1 to 2 months of active motion and strengthening with physical therapy.